All right, I think we're going to go ahead and get started. As we're getting towards the end of the day, everybody has stayed awake, and so we'll have this one last session. And I know we sort of have come off a little bit of an emotional session, but you will see we're going to switch gears and really focus this on the patients who have completed their oncology treatment. They have not finished their cancer experience, but they have finished their treatment and some of the issues that go forward from there. And you will notice a lot of similarities to the conversations we've already had in terms of training of medical staff to deal with these issues, access to long-term follow-up care, and some of the difficulties in getting the kinds of things that we need, and also what are the right models for delivering long-term follow-up care or late effects care. And I think we have a great selection of speakers. Dr. Noll really focusing on how we help parents go through these transitions and support their children. Then we have Dr. Schwartz talking about that initial experience of finishing therapy and moving on. And then Dr. Effinger, who has been very, very active in this field for a few years, who is going to talk about models and what really the needs are in terms of long-term follow-up. And I will tell you that most of my patients will say the absolute scariest or worst day of their lives is the day that their child was diagnosed. But many will also say the second worst day is the day they stopped their treatment, because that treatment and that team that's taking care of you is really become part of your family and a crutch, and you feel like you're actively doing something, and then you're being told that we're done, we don't have to actively do anything. And that's not really the truth, because as you heard earlier today, there are a lot of other issues that come up subsequently. So without further ado, we'll get started. Dr. Noll?
It's really my honor to be here today and have this opportunity to talk with you. This topic that I've been given related to transitions and families and peers is fairly broad. So I'm going to try to focus on two aspects of it. One transition is the initial transition of what happens to families when children are first diagnosed, and then a second transition related to how kids fit in with their peers, measurement strategies, and come back to the patient-reported outcomes issue and how that might be evaluated. Uh-oh. Ah, thank you. It's left-handedness. So I have also no conflicts of interest to disclose, but I do want to point out that I have also been involved with the Maddie Miracle Foundation in terms of trying to develop standards of care around taking care of children with cancer and their families. The initial part of my talk today will really focus on one element that I think has extraordinarily powerful evidence that should be distributed to every newly diagnosed family, and the other one will end up with a question in terms of where we need to go in terms of standards of care. So everybody in this room already knows that when children are diagnosed with cancer, it has a huge impact on kids and their families, and it goes all over the place in terms of these impacts. And I want to just hone in for a moment, especially on moms, in terms of their children and the impact of especially moms in terms of their influence on the psychosocial adjustment of kids across multiple domains. And that many times we see that where parents, but in this instance I'll focus more on moms in terms of our data, really are able to sort of pull things forward in terms of how they provide care and how they're able to sustain their families moving forward. And if these parental elements are so significant, then the question that our research group began to look at was, what kinds of things might we be able to do to help parents early on in the course of their transition from being parents of typically developing kids to parents of a child who's facing cancer, to help them with that. And what our group came up with was a model that we call the Bright Ideas model. Bright stands for optimism, that you can begin to do things and solve problems for yourself. And it's really a problem-solving coping model about teaching parents a set of skills around optimism and how you could be systematic about trying to take these challenges on that everybody talked about earlier in the day. How you could have a set of skills that you could use to be able to advocate for yourself and your children. And the idea of this, you can see from the little graph that I put up here, is first to identify what a problem is, define what your options are, evaluate your options, act, and then see if it works. So bright ideas. The Bright Ideas model came from an adult behavioral intervention called problem-solving therapy, and we changed that. We changed it very consciously in our group to problem-solving skills training. We changed it to training because all of us who were clinicians felt like saying to parents, you have depressive disease, you have anxiety disease, you have psychiatric disease, was a disservice to any parent of a child recently diagnosed with cancer. So we changed it around and called it problem-solving skills training. And the idea is that cancer is a trauma or a stressful or upsetting life event, challenging life event, whatever language one wants to use, and that could you come up to families after this diagnosis was made, offer problem-solving skills training, improve a very specific set of coping skills around problem-solving ability, and that would then lead to parents having less distress and better skills to look out for themselves and their children. And you'll notice here that we have sort of two pathways about this. One, a pathway through problem-solving skills training, and a second one related to lots of the conversation earlier today about relationships and how powerful they are. And you're going to see as I go through this how we've tried to dissect some of these also. So I'm going to take you through a fair amount of your tax dollars now in terms of how this all unfolded, because it involved several R01s, which are expensive NIH grants, and an R25 to see if we could do this, and some current work that we're doing and where I'd like to see this go, and then I'm going to transition to the social issue for children with cancer. So our first question had to do with, if we came into the room after a child was diagnosed with cancer, would parents even let us come in the room to talk with them about skills, and would you like some more coping skills? And everybody in the room might be saying, well, of course they would, but we weren't so sure about that. And even though we were fairly certain as a group that parents were very distressed after their kids were first diagnosed, we felt like the onus was on us to collect these data and show that. So the first project we did was an efficacy trial. Can you do it? Then I'm going to talk about problem-solving skills training compared to usual psychosocial care, which varied because we did it at 8 different sites in 4 languages. Then I'm going to talk about problem-solving skills training compared to non-directive supportive therapy, which is a powerful alternative. Many of you, if you've gone to see somebody because you were distressed about something in your life, may have had this kind of treatment where somebody simply sat and listened to you and reflected. So that was the comparison. And then our current project which is funded, which is face-to-face problem solving versus online. So the eligibility criteria for these studies is fairly straightforward. We bounced around a little bit on our first point because our first pilot group of families told us you should have come by sooner. And so we tried to come by sooner, and we learned very quickly that we probably got some bad advice, because if you come by sooner, everybody's in way too much turmoil. So we moved it back a titch to 4 to 16 weeks, any type of cancer, within 50 miles of the center. And I put an asterisk there because if this was a child with osteogenic sarcoma and the family lived 200 miles away and they were going to be living in the hospital constantly, we would take them on. If it was something where they lived a long ways away, a Wilms tumor stage 1, we probably wouldn't have taken that on, but that's what the 50-mile is. And we've done this now in English and Spanish. All of our materials are readily available in Spanish. Should you be interested in our materials, you can email me. They're also on the NCI RTIPS website that you can download. And we also did this in Hebrew, in Spanish. These are data from our first study, and by the way, I don't have my references on these slides, but they're in the notes. So if you get this set of slides, you can look at the notes and their references for all these data that I'm showing you. But these are data from our first study after we showed that we could do this, where we did problem-solving skills training compared to treatment as usual, 8 sites, and we clearly showed that if we did problem-solving skills training, we could reduce distress in parents much more quickly than care as usual. And care as usual, as people have intimated across the course of the discussion today, varied pretty significantly across our 8 sites. I was in Cincinnati when we did this first trial. We had a very large and robust psychosocial team, and I have to tell you, I was quite distressed personally that my treatment as usual team didn't do as well as the problem-solving skills training team did. We were also very aware after this trial that maybe it was just sitting with somebody, that it didn't have so much to do with problem-solving skills training, although in this paper we report mediated outcomes, which is a linkage between learning more problem-solving skills and that accounting for the variance in terms of reduced distress. But we still felt like we needed to go back and look and compare problem-solving skills training to non-directive supportive care. And this was the next study. And what is most impressive to our group from these data is what happens over time. And up in the top left corner is problem-solving skills. And you might expect that if you teach problem-solving skills, your group better have better problem-solving skills, which indeed they reported, and that was sustained over time. But the other 3 graphs in the bottom left corner is depression, and then bottom right corner is symptoms of post-traumatic stress, and the top right corner is general distress from a measure of distress. And what you see there is that after you stop the supportive counseling or therapy, the groups separate quite nicely. And by 4 months later, where you teach skills, parents' distress, depression, symptoms of post-traumatic stress disorder continues to go down over time, whereas the parents who were getting the non-directive supportive counseling or therapy, their distress levels off, and those are all significant differences. So our conclusion from this series of grants that we did with over now up to 1,000 parents is PSST is acceptable to families. You can go in the room and do it. I'm going to talk a little bit even about our current trial and how we've even gotten better at doing that. It's effective. It reduces maternal distress. And for those of you who might be sitting in the audience going, well, why are you focusing on moms? We focused on moms because they're the ones who are there. And our current trial is actually trying to engage more fathers every which way that we can, but it's hard to find fathers all the time on the floor. And most impressively from our perspective, problem-solving skills training is most effective. It's effective for everybody, but it's most effective for minority mothers, low SES, and single moms. So this has sort of become our mantra in terms of problem-solving skills training and why you might begin to think about this in terms of what sorts of services do you provide on a pediatric cancer unit related to these thoughts about standards of care and what we might be thinking about doing. From the perspective of behavioral health research, problem-solving skills training is efficacious and specific. This comes from Chambliss's criteria in terms of psychotherapy and behavioral health research, and we now have 2 large randomized clinical trials. We've identified the specific mechanism. We know that it doesn't cause harm. We know that it's effective. And I can tell you yet, if you ask me today, how many centers routinely offer problem-solving skills training when families are first diagnosed. There happen to be 4 centers in the United States that do that, and they're the 4 centers that are currently involved in the R01 that I'm going to talk about now. So the problem is that the intervention is labor-intensive. It requires trained personnel. Up until now, we've required people, our RAs, to have at least a master's in terms of their training. And we have 2 solutions that we've begun to move forward with this. One is to increase accessibility. And so I'm going to now talk about a current project that we're doing that's funded by the National Cancer Institute, and then a second project that's out for review to try to build capacity. So I'll just mention quickly the second project, which is a project to partner with the Children's Oncology Group, Society for Pediatric Oncology, Society for Pediatric Psychology, Special Interest Group in Pediatric Cancer, the Pediatric Oncology Nurses, and the Pediatric Oncology Social Workers to do workshops training individuals at every pediatric cancer center in the United States to be able to deliver problem-solving skills training at their sites. And built into this R25, this dissemination grant, is also some train-the-trainer models so that we'll have certain individuals back and try to train them to become trainers so that they can really disseminate this model within their sites. Our online project, which is a current R01, which is RCT number 3 related to problem-solving skills training, is problem-solving skills training compared to electronic problem-solving skills training. Part of our motivation for this not only was about the manpower issue, but it was also about families and what do families need. And when families wake up, when moms in particular, but you could do dads, wake up at 4 o'clock in the morning and they can't sleep, and they'd like to look at these problem-solving materials, we thought maybe this would be a really useful way to do this. So these are the same criteria that we've been using before. This is now a project that's going on in 4 centers. And related to the recruitment issue, since I've now been involved with 4 problem-solving skills training studies, we nearly recruit 100% of families in Pittsburgh. How do we do this? Because my research assistant goes to tumor board. My research assistant talks to the doc when the patient's first diagnosed. My research assistant gets help from the pediatric oncology nurse on the floor to meet the families, and she drops by in week 1, week 2, week 3. How are you doing? We have this project, and we recruit close to 100% of eligible families into problem-solving skills training project that we're now is ongoing. This is an equivalency trial. So the idea of this is to see whether or not problem-solving skills training is as powerful electronically as it is face-to-face. It's ongoing. So I'm going to shift gears dramatically, although I'll come back to problem-solving in just a second, And I want to talk about peer relationships and children with cancer. And I want to highlight the first line of this slide having to do with source of information. I would guess everybody in this room knows that peer relationships for children are extraordinarily important. If you don't, I can tell you that they are. I can also tell you that how you measure them matters. And this would be a one place, very few places I would take issue with Lillian, but this would be one where I believe that collecting data from peers is more reliable and predictive in terms of what happens for kids. Peer reports tend to be stable over time. They predict things. They predict dropping out of school. They predict going to jail. They predict occupational success. They predict making more money. And so because of that, I've really wanted to look at what happens to children and their peer group. We've used two sets of measures: what are kids like and are they liked? And to do this, what are kids like, we give them a play, and their job is to tell us who could play different roles or parts in this imaginary play. And these are data from our lab for long-term survivors of pediatric cancer from 120 different classrooms. And these are all kids who are done with treatment, and you could see their peers still know there's something wrong with them. But what we were really interested in, and we thought, was that cancer survivors would be more isolated and victimized. And this is a group of non-CNS tumors, and there's really no evidence. The only difference that we get is that cancer survivors are less aggressive and disruptive from the perspective of their peers. We also thought they would have fewer friends and be less well liked. The data didn't support that either. Using the same strategies and measurement techniques, we looked at brain tumor survivors. And these are data from Kathy Vanatta's lab from multiple sites. And you can see here kids who are cancer survivors, these are an average 3.5 years after diagnosis, are lower on leadership, much more sensitive, isolated, and victimized. They're not well liked, and they don't have friends. This is a problem. So from my perspective, to go back to PSST and to show you the Bright Ideas model, it works something like this. The first question is, when you try to understand what the problem is, who's involved? And so my answer is, when I really look at social functioning in children with cancer, the group of kids who are at very, very high risk are brain tumor survivors. What are they at risk for? These are the things I happen to be the most interested in, which is peer relationships and how you're viewed by your peers. And I just want to add one other thing. When these data are collected in classrooms, nobody knows why we're there. So these are data from 25 to 30 other kids who may or may not know they have a classmate with cancer, but they don't know why you're in the room. They're simply telling you about their peer relationships. So I think the target needs to be social isolation and low acceptance. It happens at school. And given the stability of these things and the things they predict, I think this is a major challenge in terms of standards and what we need to be doing for children with cancer. We don't know when this happens. So I'm going to guess, based on looking at other groups of kids with cancer, that it doesn't happen right away. So that when kids with brain tumors go back to school, initially they might look just like the other data that I showed you. But over time, something happens for this group of kids where they're really having some, not only, I think, some neurocognitive problems, but also some significant social problems. And I think we need to begin to think about when this unfolds, because if we're going to allocate resources, we need to target them at the right time. And my last question is, why? Because what is the target? I'm not so sure that these kids lack social skills. They didn't lack social skills before they got their brain tumors, and maybe it has more to do with neurobiological processes related to processing speed, working memory. I'm not sure. But I do know when you use the Bright Ideas PSST model The first step of it is to understand and identify what the problem is. And before you can begin to come up with solutions, I think we really need to think through what exactly is the problem. Thank you.